Welcome to Deuk Spine Institute. We are operating on a Wednesday, September 4, 2024. Our patient has facet joint pain, and we're going to be treating both facets on both sides. And so he had the Deuk laser disc repair. His leg symptoms are gone, but he still has facet joint pain. So we're going to be treating his facets today. Okay, we're going to use the X-ray to identify the transverse process junction with the superior articular process, and we're going to start with the left side. I have to talk to my technician for a moment, so bear with us as we get oriented. That's 5, 4, 3, 2. I can't really see the TP at 2, 3. I think you're zoomed out too much. Let's get zoomed in a little bit. All right. I don't know if this light is in my eyes here. I can't really see. All right. I can't really see the TP of 2. There's 5, 4, 3, 2. All right. There it is. Just stay where you are. I can see it now. I'm going to try to do everything with one incision right here. And see if we can't get them all done with one incision. I may have to make a second incision. The incisions are 4 millimeters, and this procedure we do is a permanent facet joint treatment. Unlike an RFA, which is temporary, which is done all over the world, radiofrequency ablation is a temporary procedure. This is a permanent elimination of pain. I think that looks pretty good. Yeah, let's get him a little bit deeper. All right, shot. So the target here, if you see the, Monica, show the audience the pedicle. Up above where I am. Yeah, that's the pedicle. Good. Now, shot. The transverse process comes off the pedicle. My probe is right on the transverse process. And that's exactly where we need to be. Let's do some more local. I mean, I need deep local, okay? Not skin. It's not the skin hurting him, Luis. We're giving you some more numbing medicine. He's had a laminectomy before, so there's a lot of scar tissue here we're dealing with. And that makes it a bit more challenging, but we still can get it done. I didn't do his laminectomy shot. Okay. You can see the transverse process up there and shot. You can see the arthritis in the facet joint as well. That's one down. Shot. It's a little too high. If you have questions, feel free to ask them. We'll take your questions. Shot. Henry?
Yes, sir.
If there's no questions, let's show the audience how it is that the facets are so painful. Shot? In some patients.
Copy that.
Okay, you can see from the video that the facet joints, they get inflammation from arthritis, and that inflammation will then cause pain. And those pain signals travel to the brain where they're interpreted as pain. Shot. I'm trying to dock the tip of this probe right where you guys can see it there, that's where the pain nerve is. It runs just lateral to the facet joint and innervates. Huh? It's perfect. It's perfect. No, it's okay. Shot. All right, that's 2 down. I'm sorry? You know, it's hard for me because he's got all this scar tissue. Shot from his laminectomy. Yeah, he's had several surgeries. He was told where he's from that he needs to have fusion because he's unstable. But that's not true. He's not unstable. His spine is fine in terms of stability. It's just hurting him. Shot. All right. That's it right there. Can you hone in on the TP of 4 for me a little bit more? I think you have to change your angle just slightly. I don't see the TP of 4 that well. And then 5, he's got a very large transverse process. Shot. Shot. Just take a shot. Don't move too much. It's the wrong direction. Stop. Shot. That's probably okay. He has a very small TP here that I'm seeing. All right, just leave it there. I see it now. It's just much smaller here. I don't know why. That's just the way he was born. But his TP at 4, transverse process at 4 is small, but his TP at 5 is huge. All right, shot. I think I'm on it there. Too low. Shot. That's looking pretty good there. Feel like I'm on it there. Shot. Feels needs to be a little bit higher. How's he doing? I'm having to get through the scar tissue. It's not easy. You can see the tip is right near the TP. Shot. That's probably the bottom of the TP right there. Shot. I'm on bone, which must be the TP and the facet. I can feel the facet. Shot. As I said, it's a very abnormal TP over here. That's it. All right, we're done with that one. We're going to go to number 5, and then we have S1 as well.
We have a question.
Sure, shot.
Coming from AAKK on YouTube.
Welcome. Welcome to our stream. AAKK.
Saying, hi, Dr. Deuk. You may have mentioned this before, but what patient's exam/history led you to treat his facets versus performing DLDR?
So he had the DLDR. Originally, he had leg symptoms with neurogenic claudication, clearly had pinched nerve, and he had discogenic back pain. I examined him. He had no facet tenderness, no facet pain. Facet pain is lateral. It's to the side, and he didn't have any. And so I just did his discs, and his disc pain is gone. His leg symptoms are gone, but he has pain on the side of the spine. The facet pain typically is about 2 finger breadths to the side of the spine. So it's just lateral. All right, now I got to get down to 5-1. That will be our last on this side. Let's see if I can do that. Shot. Close. Very close there. So when I recognized after his surgery that he still had pain on the lateral side of the spine, that's when I realized he has facet pain. And I confirmed it on exam. He had tenderness of the facet joint. Okay, I'm going to go to the other side And we're going to do the same thing on his right side that we did on the left. And I think we're okay there, Monica. 2, 3, 4, 5, 1. Yeah, the right side looks, you know, I hate to say easier. Easier is not the right word, but it looks better defined. The anatomy looks better defined. Shot? Yeah. All right. So hopefully that answers your question about why I decided to do the DPR.
We have a follow-up from AA, KK, once more on YouTube.
Sure.
Saying, excellent explanation. Thank you, Dr. Deuk. Is it possible that the change in his posture after curing his disc pain present as new facet pain, likely from underuse due to discogenic pain guarding?
Yes, you're 100% right. That's brilliant. I'm impressed with your understanding of biomechanics. That's exactly right. And that's a hard thing for me to explain to patients a lot of times, is how fixing one thing changes their biomechanics. And they start to walk different, stand different, and they can load their facet joints, whereas they weren't loading them before. So before his disc surgery, he was hunched forward quite a bit. Shot? So I'm right on the TP, but I'm too far lateral. I want to be a little bit more medial. Shot? And so by changing his gait and stance, he's now loading those arthritic facet joints, and now they're starting to hurt more. So you are correct. That's right. That's what's happened. Shot? All right, I'm just at the bottom of the TP. There's the top. Shot? Yeah, that's fine. So we're in the right spot. He's got a little bit of scoliosis. No problem. I've got a few more minutes on this one, but he's reacting a little bit, Dr. B. Yeah, I did some numbing medicine, so I've done what I can. All right, if you have any other questions, I'll take them. But we're going to finish this in about 5 minutes. And shot. I'm just working my way down. You can see the arthritis in the spine. Shot. As you do this technique, it's very important that you're on the bone. See where the tip is? That's the absolute perfect spot.
Yes, we see it.
That's where the pain nerve lives, and that's where we have to cauterize the pain nerve. Pain nerve is called the medial branch of the dorsal ramus, and this is a technique that I pioneered because RFAs don't work. RFAs don't last, and you know, I started to ask why, and once I realized the reason why, it was quite obvious what needed to be done to me. I don't know why the rest of the world hasn't figured it out, but it's a surgical procedure, and it's not a hard procedure. It's very similar to an RFA. You're targeting the same nerves as an RFA, but instead of just putting a little skinny probe and burning, you are cauterizing with more energy, but plus you're wanding. The wanding is very important. Have to wand. If you don't do the wanding, you're not going to destroy the pain nerve. Shot. Again, docking right where the pain nerve is. That's the spot right there. You see the pedicle on the AP view. You notice with this surgery, we don't change views to a lateral view. Everything is done with an AP view. You don't need a lateral view, but you do need to feel the target. You need to feel it with your fingers. You have to feel with the probe that you're in the right spot. All right, one more to go, and we'll take the last question or two, and then we're going to end, and we're going to do his cervical spine next. So we'll be back with a cervical DPR.
Yes, last but not least, coming from Lanu on YouTube,
Shot.
asking, after the surgery, do patients must have someone to escort them home?
After this surgery, yes. He's here with his wife, and she will drive him back to his hotel. All right. We're done with the lumbar. And any other questions?
No current questions, just a comment from AAKK saying thank you. That makes perfect sense from a mechanical
let's show
aspect.
Them. Pull out. Let's show them the incision.
Copy that.
Pull the fluoro out so the camera can see the back. Can you guys see this?
Yes, we can.
So 4 millimeter incision. 4 millimeter incision. And I treated L2, 3, 3, 4, 4, 5, 5, 1 on each side. That's it. There's about, I don't know, a cc of blood loss, and that's it. We're going to go on to the neck. Thanks for joining us. We'll be back in just a minute.